So, good morning, good afternoon, good evening to the IHF members from across the world joining us today for this webinar. And on behalf of the Women in Leadership Special Interest Group, in collaboration with Icon Group Australia, welcome to today's webinar, where we have a fantastic panel of women leaders who will share inspiring stories on their work to bring about transformative change in the health of the most vulnerable women in society. And I hear many of you thinking, but the health of women shouldn't rest solely on the shoulders of women leaders. So, full points. Absolutely, we agree. But today, we really want to celebrate some of the fantastic programs led by women and look at them with a gender equity in leadership lens. Do women leaders have something extra to offer in reaching hard to reach and vulnerable women in their communities, through role modeling, through building trust, or their lived experience? We'll see. And before I hand over to our chair for today to explore these issues a bit further, just the usual housekeeping requests. Please keep on mute and use the chat function to introduce yourselves, to add your comments, or ask questions for the panelists, and we'll come to those at the end of all the presentations. So on our panel today, we're honoured to have Dr. Kavita Balekar, who's the Chief Nursing Officer at Reliance Foundation Hospital, India, and she has kindly stepped in at the very last minute when our original speaker was called away to deal with an urgent situation. Jane Wanyama, the CEO of Aga Khan Hospital, Kisumu, Kenya. Dr. Amanda Madrid, CEO of Predisan, Honduras. And Amanda deserves special thanks for joining us at 5 a.m. So thank you, Dr. Amanda. And now it is my absolute pleasure to hand over to our chair for today, Margie Horth, who is the Director of Nursing at Icon Group Australia, where it's also 9 p.m. So we're really spanning the globe. Margie, over to you.
Thank you, Elena. So hello, everybody. Thank you for joining us. My name is Margie Horth. I'm the Group Director of Nursing at Icon, and I have the genuine privilege of leading nursing teams across Australia, New Zealand, ASEAN, and the UK. And every day, my focus is on supporting our nurses to build the skills, the confidence, and the leadership capability needed to deliver exceptional cancer care. And through my role, I've also had the opportunity to work with incredible global partners, including the City Cancer Challenge and the International Hospitals Federation, contributing to initiatives that aim to reduce the global cancer burden and strengthen health systems in meaningful and practical ways. So Icon is a proud supporter of the IHF and this webinar series, which plays such an important role in knowledge exchange and networking across the global healthcare community, and embodies Icon's mission of delivering best care possible to as many people as possible, as close to home as possible. It is an honour to chair today's session and be part of the lineup of incredibly talented and committed women in leadership who are going to share their stories and experiences about how they're driving transformative change in underserved communities around the world to overcome the barriers of equitable access to healthcare and wellbeing support systems for women worldwide. And as you've heard from Alona, over the next 60 minutes, you'll hear from our panelists, and then there'll be an opportunity for discussion at the end. So as we delve into the session, I encourage everyone on the call to share your experiences and post your questions in the chat. So I'd like to begin the session with a case study that is very personally close to me and one that speaks directly to the theme of today's discussion. In 2021, I had the privilege of delivering a patient navigation program in Kigali, Rwanda, in partnership with City Cancer Challenge team. This program focused on developing nurses in leadership skills to implement a program that strengthens cancer care pathways and improves access, coordination, and outcomes for the people of Kigali. I won't be able to capture all of the detail of the 10-week program in 7 minutes, so I'm just going to focus on the element that aligns with the theme of this webinar. That's the significant value add nurse leaders have on meaningful and sustainable patient outcomes. The patient navigation is such a powerful way to deliver on Icon's mission, bringing that best possible care to more people closer to home. Through the patient navigation program pilot, nurse leaders translate a complex cancer pathway into a more coordinated, supported, and understandable experience for patients. The Kigali project demonstrated that with the right model and practical resources, patient navigation could be adapted to a local context and strengthened across regions and countries. I'll share the story of one woman because this clearly demonstrates why the patient navigation program was needed. So Matoni was 30, recently postpartum and breastfeeding when she noticed a small lump in her breast. She initially thought it was related to breastfeeding and delayed seeking care after being reassured by others in her community. But when the pain continued, she moved through a series of referrals from a health centre to a district hospital to referral centres in Kigali, travelling 4 hours from home with her baby and repeatedly returning for investigations, diagnosis and paperwork. By the time she met the patient navigator, she was exhausted and frightened. She'd been told she needed surgery and chemotherapy and would need to stop breastfeeding, which left her feeling hopeless and worried about who would raise her baby. So the patient navigator explained the tests and the treatment, supported her with appointments and paperwork, and connected her to other navigators when she moved amongst services, and linked her also with a support group. But most importantly, that patient navigator made the pathway less daunting and gave Mutoni hope that she would be there to raise her child. Mutoni's story is very personal, but unfortunately it's not unique. It reflects the experience of many women in underserved communities who face real and often overwhelming barriers to accessing timely cancer care. For me, this is where the value of nurse leaders and patient navigation becomes clear, supporting women like Mutoni and their families so that they can keep moving through the care that they need. So Mutoni's story helps us understand what these critical gaps in care mean. The City Cancer Challenge Needs Assessment confirmed that the patients were facing late diagnosis, fragmented pathways, treatment delays, and were often lost to follow-up. And behind each of these barriers to care is a woman trying to navigate a very complex system. The patient navigation program was designed to respond directly to those gaps by strengthening communication, improving data sharing between the services, and supporting patients from diagnosis through to the end of their treatment. Once the gaps were clearly identified, the focus became about how to connect the system around the patient. So the solution in practice was a nurse-led navigation model that connected patients, services, and information across the cancer care pathway. Training nurses to lead the implementation of the program was central to this model, as they bring the patient's voice to the multidisciplinary team, coordinate next steps, and turn decisions into actions. Supported by technology and international collaboration, the program was delivered to nurses across 5 city hospitals. The program created a practical way to share expertise and build a model that could extend beyond Kigali. The model developed, the next challenge was a delivery. We were going to actually go to Kigali to deliver the training face-to-face, but COVID required us to pivot really quickly. So rather than delay the training, City Cancer Challenge and ICON redesigned the program, keeping the focus on practical implementation and building nurses as leaders in navigation. The result was a 10-week virtual pilot with 5 nurses across Kigali, delivered 2 hours a week and focused on developing the leadership skills and the knowledge needed to implement patient navigation in practice. The Kigali program delivered measurable impact. With nurse leadership at the centre, there were more than 1,350 patients supported, with faster access to treatment and strong patient satisfaction. The reduction in time to treatment was from 82 days to 28 days. And this shows how nurse-led coordination can increase access to best care possible closer to home. The training program also built nurses as leaders and established a train-the-trainer model, creating capability and sustainability well beyond the pilot. The data only tells one part of the story, and the strongest evidence of impact comes from the people who experience the program directly, from our patients, our clinicians, and so as you can see from the comments on this slide, the message is clear, and together they reinforce what Mutoni's story showed us, that navigation changes the experience of care. Patients, clinicians, and nurses all describe the same impact, care that feels more coordinated, supported, and centered around the person and not just the system. This links directly to today's theme, nurse leaders in health, improving the lives of vulnerable women by turning practical nurse-led actions into meaningful patient impact. To close, I'd like to share the CEO of City Cancer Challenge, Isabel Mestry's reflection that this program responds directly to a need seen in every City Cancer Challenge city, the need to strengthen local capacity and improve equitable access to cancer care. The success of this training program in Kigali demonstrates the power of nurse leaders who turn practical learning into meaningful change and improve access to care for women in underserved communities. To support sustainability, the Kigali model has been translated into a multilingual video training course now completed by nurses in cities including Kumasi in Ghana, Tbilisi in Georgia, and Lyon in Central America. This is an example of what women leaders in health make possible. They connect people, build capability, and create lasting change where it is needed most. Thank you. the last slide worked. So thank you, Alona. Now I would like to hand over to Dr. Kavita Balakar, the Chief Nursing Officer at the Sir H.N. Reliance Foundation Hospital in India. Thank you, Dr. Balakar. And good luck with the presentation.
Good evening, good morning to all those who are there on this call, and thank you for calling me. And I represent Reliance Foundation Hospital in India. I'm Dr. Kavita Bhalekar. I'm the Chief Nursing Officer and the topic basically today is very apt, and I'm really very inspired by Ravada for your patient journey actually. So that's where then we all actually start with when it is related to the woman and the care that we require to give for the woman. So as women leaders, healthcare does have women as the leaders. So it is basically two frontiers and one responsibility. That's how we see it here at Reliance Foundation Hospital. So it is a leadership, basically led by a woman. Definitely, my chairperson is also a woman, and we do a lot of community activity here in India. Though our numbers are not that great to be at the global level because it is a initiative by one organization in India, but let me have the presentation to you and then we can have the discussion. So further leadership, basically what we think is we must enable women to lead. So that is creating opportunities for them to be accountable, sponsor them, and not only be visible, but also be able to take responsibility. It is a talent, basically. And in the access, it is not the system that should facilitate, but reaching out to the woman and not wait for the woman to come to us. So as we said, that it should be a co-relationship basically. So it is through community driven initiatives that is like prevention, screening, diagnosis, treatment, follow up, and connected pathways that will help the vulnerable women of our system and the health ecosystem, because it requires talent and the care pathway to marry itself. So if it gets married together, we have a very strong way to trust, sponsor, and empower the woman in getting the healthcare. So that's what we believe here in RFH. And in the global paper, actually, that was presented by WHO on women in global health, it stated that it is delivered by women but led by men. And very rightly so. Only 25% of the senior leadership of the women are 25%, whereas the workforce consists of 70% of women. So if it is a woman delivery done, then it should also look at the fairness, basically, because if the talent is not tapped, then it is a lost talent. The talent needs to be tapped because this is a representation of a meaningful match of responsibility. We need to have representation to authority. So basically the questions that we ask every year is, do women have the real access to operating roles, transformation mandates, sponsorships, budget and P&L, board visibility, and succession pathways? So in the, not only in nursing, but across the administration, as well as in the revenue cycle or the marketing or any department which is there, we try to see that we can bring in the leaders of tomorrow, the young generation, which requires to understand how important it is for their own health as well as the health of the community that they are serving to. As we say that the workforce is around 70% is in healthcare system, at least women driven. So when women is healthy, families are strong, our communities and economies are stronger. That's where then we have the WHO, we have the JCI, we have IHF, we have the Geneva, we have so many of us talking about it because we all want that the entire economy as well as the community becomes stronger. And that is the basic crux of this webinar, which I'm really so happy and passionate to be part of completely. So when we are talking about women spend only 25% of their time for their own health. If we see the World Economic and McKinsey blueprint, which was submitted and updated in 2025, only 25% of the women spends time on their own health. 75 million years of life lost to women's health gap every year. And 1 trillion is the GDP in 2040 that we need to gain. And for every dollar that is spent, okay, that is a $3 investment done in case if we are having women leadership as well as women health taken more into accountability. So we will be able to lead our health systems with empathy, discipline, budget, and accountability. So that's basically from the global stakes. So when we come down to what we have, coming to my story, basically I am a nurse. I started with a bedside nurse and moved on from bedside to the boardroom. That is wherein I worked from UAE and India and got my fellowship from American College of Healthcare Executives, done my MBA, as well as the quality is basically to understand how health systems can be built. It is all related not only to that one hospital that we need to be. We require to be able to propaganda and to bring in systems wherein we reach out to the mass population. Even with screenings, we should be able to reach out to them. So that's the journey when we talk about that excellence must travel. It should travel beyond the walls of the hospital. So when we have primary care being given, outreach programs being given, we try to see that we have hospitals without boundaries, without walls, so that there is a continuity of care and access is given. Prevention model is definitely there and you scale up the system. So this is basically what we were thinking and we spoke about. Even in my colleague had mentioned that it is more about the time that is being invested, the mobility, the awareness, the financial independence of a woman, the decision-making power of a woman, the privacy and trust of a woman. I mean, these all are the circumstances which actually deprive or hinder, I don't say deprive, but hinder her from taking the health facility that is even available. So even when we go to the outreach programs and we try to bring in people to talk about their own health or to follow up, because with screening, we do screen and tell them, okay, you need to come for a breast cancer or a cervical cancer. But how much is it that she actually comes back to us? That's where we need to go back to her, is what we understand. So are we design care programs where we meet the woman where they are? So meet the patient where they are, earn and keep respect, stay connected beyond the first consultation, empower women clinicians in complex settings. And this is actually the vision of our founder and chairperson, Srimati Neeta Ambani, wherein she says that we don't just treat health, we respect for life. And I will actually share with you. So this is our outreach program that we have actually touched so many individuals, actually more than 140,000 plus individuals where they have got screened for, and so many families that we have been able to actually deliver and take care of. So when we say that we are hospital beyond boundaries, beyond the walls of the four walls, this is what we mean to say. And in the women health, we focused on basically cervical cancers, anemias for the women. So this is two programs that I'm actually presenting over here, because there is much more than what is actually done out there, because we have actually diabetes, hypertension, cataracts. There are so many programs. I just got two programs here on the platform to share it. Why? Because the burden of this is too much, is too high. So even the WHO states that this burden is really very high and can be preventable. It is really preventable if we are able to take care of it in the right time for the women, basically. So it starts from adolescent. Okay, so in the adolescent age, we have the HPV and the vaccination camps for the women. In reproductive age, we have the anemia and nutrition for them, wherein we have our doctors, we have our team. There is a full team of 10 plus people who go to the area, whether it is mobile and to remote areas, along with our entire team, and try to do all these screenings and the continuity. And wherever we require them to have the treatment, then they are got back to the hospital, and under our charity wing, we actually deliver even surgical treatments for them. So this is actually what we try to do for the entire population. So right from adolescent to reproductive age to adult women, whether they are diabetes, hypertension, and high-risk women with breast and cervical screenings. So these are some of our numbers that we were able to achieve and still going strong. The program is still on completely. So at RFH, basically, we believe that design for women's life is all about how we reach out to them, make screening at the entry point, that is at every step that they come in, that the first thing that we do is have an entry point. We pair technology with trust, lead with sponsorship, measure our goals. That's what I was able to share with you, and hold scale and dignity together. Because without dignity and without making them responsible and giving them that trust that we are there, they would not actually come out and talk to us. We require to find them first from the community. Then we need to build trust with them. And then we need to tell them, okay, we are here to handhold you and continue your journey of health improvement. So our success basically depends upon how we receive the timely diagnosis, the treatment, and connected with them. In leadership, we make every woman capable to be visible and the opportunity is given to them. In healthcare, we ensure that the health and illness do not occur, because screening is something that we would definitely want to achieve on. So we reach to open the doors, and continuity creates the outcomes for all of us. So that's basically with how we would want to have the leadership, and that's what our leadership actually delivers also in all the frontiers within the outreach program for all of us. Thank you
so much, Dr. Balakar. That was so interesting, and I can sort of already see themes that are aligned with, you know, things that we do, and like creating opportunities and career paths for women, because how else do they get to those leadership positions? And then with the community, and just building those care models around the women rather than the system. So thank you so much. You're doing amazing work in India.
Thank you so much. Yeah,
great statistics, right? Yeah,
it's a drop in the ocean, but it's better to start and have the women take care and lead with it. So thank you so much.
Thank you. That was fantastic. You're really making a difference. So thank you. Now I'd like to hand over to Jane Wanyama. Hope I got that right, Jane. Jane's the CEO of the Aga Khan Hospital in Kisumu in Kenya. So welcome, Jane.
Thank you. And you got it right, Jane Wanyama. So we'll go with it. So my name is Jane Wanyama. I'm the CEO of Aga Khan Hospital. I'm the CEO of Aga Khan Hospital, Kisumu. I'm going to take you through a presentation that I thought I'd call Women Leaders for Women Health. Just looking at what our topic was. So first of all, of course, I'm a nice girl from Kenya, western part of this country, a place in which most of the girls or women are deemed as lesser persons in the community. Traditionally, women do not have control over so much, including their own health. And in many households, it's male people that take dominion. So additional to that, it's a community in which there are so many myths and stigmas that impact women's health, and even just girls and the decisions that are made about girls. So for me to be what I am today as the CEO of Aga Khan Hospital, Kisumu, it's a plus, and really a great place that AKHS has given me the opportunity to be the CEO of the institution. So briefly, this is Aga Khan Development Network, bringing in where Aga Khan Health Services is. It's under the social development arm, and we are across Central Asia, and Africa in most of our other areas that we operate in. So the Aga Khan Development Network Health System has 4 areas that we focus on, mainly population health, And our main focus has been on maternal and neonatal and child health, in addition to some of the NCDs, especially in this season. And we also look at service delivery, and that is what most of us are known for. We have a number of hospitals across the region that I talked about. One of our main focus in service delivery, and what sets apart is the quality of healthcare services that we ascribe to. We also focus on education and research, and we also have some cross-cutting areas that we focus on as Aga Khan Development Network. Down to the health services, and especially in East Africa, we are a premier teaching and an integrated health system, focusing again, like I mentioned earlier, on best practices. For this, we have gone forward to accreditation with JCIA and Safe Care certification, which I know are mainly known to us, and really they're the engine behind the healthcare services that we provide. We also focus a lot on education. Education, in this case, starts at different levels, even from the point of clinical placements for students in our institution, to education at different levels, especially degrees through our nursing schools and postgraduate medical education. And in this also, focusing quite a bit on research, both applied research and implied research, and the postgraduate medical system. The Aga Khan University has gone a long way in being able to support even the Aga Khan Health Services in research. We also focus on a hub and spoke model, and I'll be dwelling on that in the next slide. Before then get to speak about our public-private partnerships. I mentioned that one of our focus areas is on population health. And for us to be able to do this, then we have to be engaged in public-private partnerships and private-private partnerships, which goes a long way in enhancing access. So this is the feel of the integrated care delivery system that we have. We have the hospitals right in the middle. That would be the Aga Khan University Hospital or the Aga Khan Health Services hospitals. And on it, then we have medical centers. We have outreach health centers, which is the OHC, right into the communities. We also have a home-based care system, which goes where we have patients in the community, in their homes, being taken care of by our own teams, our nurses. And together with that, then we do preventing care camps. So we call the home-based care system H2H2H, meaning home to hospital and back to home. Then we also have the camps through which we are doing screenings and getting patients to come over, referring them for diagnostics and treatment to our hospitals. So this provides a nice continuum of care through one health system. And we also are investing in electronic health record system so that there's continuity and visibility across the entire network. In addition to that, we're also providing some telemedicine services. And this is because we have a scarcity of specialty doctors, and for the patients right in the villages to be able to access some of these services, then they ride on our telemedicine programs. This is a feel of what Aga Khan Health Services is in East Africa, talking about Kenya and Tanzania, and now have a good footprint also in Uganda. But narrowing down, this is Kisumu cluster, which I lead as the CEO. As you can see, this is western part of Kenya, right next to Lake Victoria. Where we see Kisumu, that's where the main hospital started, where I'm sitting today, started in 1952. Then we have the hub. Today we have a sub-hub called Kisi, which was one of our outreach centers. It was the first outreach center, but has been expanded into a medical center with about 25 inpatient beds. Then we have the medical centers that are right in the different counties that we have. Since I became the CEO, we have had about 7 outreach centers coming on board, and we are heading to one more towards the northeastern side of Kenya, Rift Valley, actually, in a place called Lodwar, which is very, very marginalized. Just to share a bit of the numbers that we have for Kisumu only. So I have one facility. I have 14 outreach medical centers and 1 medical center. We see close to about 200,000 outpatient visits. And for inpatient admissions, we work with give and take about 10,000 now and going. And you can see that we have about 14, all our outreach medical centers are actually Safe Care accredited at the moment. So under population health, Aga Khan Hospital, Kisumu, has been involved, and not just Kisumu, actually, East Africa has been involved in a number of projects, donor-funded projects. And I thought of looking at an Access project, which we call it Access. It was access to quality care through extending and strengthening health systems in Kenya. Now, but before this, we've also had projects that have dealt with COVID, especially when we had COVID. We have had, currently we are running a project which is on cancer, East African Cancer Care for Women project in East Africa, which was an upgrade from a project that started off in Dar es Salaam. So today, talking about Access project, which I thought was good to share with us, and mainly because I'm not just, my background is nursing and I'm also a midwife. So this is a project that was very, very close to my heart. I started planning for it when I was the director of nursing. Then I was a focal point person, but got it implemented when I'd become the CEO of the hospital, where I now took the strategic role of leading and implementing this project for Aga Khan Hospital Kisumu as an implementing partner. So its main ultimate outcome was to contribute to the reduction of maternal and child mortalities in the targeted area. And for us, it was Kisii in a county called Bomachoge Borabu. We were targeting to have 1,209,617 people as beneficiaries of this project, but we were obviously able to go much higher given the need in the region. Quickly we had very many interventions that were done, having to work with community health workers, building capacity of the healthcare providers, infrastructure renovations, and working with different ministries to be able to meet our objective. And some of our key results were that the health facility was able to record a gender responsiveness of up to 75%, starting from 0. We had skilled deliveries increase from 3.4 to 83.7, initially at 80.3 by the time we were handing over the project. The facility, we had it increase being able to provide basic emergency obstetric and neonatology care services from 60 to 81%. We had all the staffs being knowledgeable about infant and young feeding, starting off from a baseline that was 60%. We also had the antenatal visits uptake increase. We had children breastfeeding also increase from 11% to 53%. And what you see here was a theater. The facility we went to did not have a theater. So they were recording very many maternal and neonatal mortalities because the patients had to drive. The women had to go about 200 kilometers away to be able to access care, and especially if it needed cesarean section. So by the time we were handing over this project, we had about 321 C-section in the year 2023, who otherwise would have either had to travel 200 kilometers to access a delivery hospital with C-section facilities, or otherwise most of them opted just to go home and leave it to God for the outcome. So some of the key learnings that we had on this project is that improving women's health requires a very multi-sector approach that addresses not only healthcare services, but also education, economic empowerment, gender equality, nutrition, water sanitation, and social protection. And this is important for us to know that improving women's health is not just about one. It's about many people coming together, many ministries coming together, or sectors coming together, that we can be able to improve the women's health. But there were some important things that came out for me on this, and not just because I'm the CEO of the hospital or a woman, but I know that it's applicable to the women in this region, and I think in most developing countries. And this is what affects women's health around us. So number one, of course, is the poverty and economic inequality. Most women, if you go to the families in our nation, is that women earn less, or they are lesser, they have less control of the financial resources in their families. And in this case, then, it means that it also affects their timely need to access care. When you look at it from an education point,
Thank
So
you.
there is the education and health literacy, there are gender norms and inequality that impacts women, like I mentioned earlier about the traditional bit of it, the access to quality, and of course, culture, food security, and water sanitation. These are key factors that affect how women are able to access care. So the challenges for myself as a woman leader also, of course, builds on what I've already said are the challenges that women face in this community. One of them is balancing leadership and personal responsibilities, because it's a woman who is supposed to be taking care of the family and at the same time be able to deliver on their professional responsibilities. There's also a bias from a gender point that women have to put in much more effort, work harder to be acknowledged as credible or leaders in authority. And of course, there's also very limited representation of women at leadership level. And so as I go towards the conclusion, is saying that when women lead, health systems become more responsive, inclusive, and equitable, benefiting not only women, but the entire families. Why? Because we understand what women go through. We understand what it takes for women to access healthcare. And we also understand what their needs are and are able to advocate and for them in policy development or even systems or health infrastructure development. And so just to say that women's health is not a women's issue, it is a community issue, an economic issue, and a development issue. Thank you.
Wow. Thank you so much, Jane. You're making such a difference. Again, there's some themes that just come through right for all of our presentations, and it's about care close to home. So having that clinic close to people's homes without the travel and the burden of finance and travel is amazing. The differences you're making in those statistics is incredible. So thank you. And then, as you said, balancing that leadership role with expectations of your culture and your community and your families is always a challenge too, but we need people like yourself leading these projects. So thank you very much, Jane. Appreciate that. So I'm just going to move on now to Dr. Amanda Madrid. So Amanda is the CEO of the Predisan Health Ministries in Honduras. So thank you, Dr. Amanda, for joining us tonight, and I'll hand over to you.
Thank you for the opportunity. I'm going to try to, and this time, I don't know, we're running out of time, but the 40 years of Predisan impact on women's health in Honduras. And I'm going to focus on the grassroots level that we started 40 years ago. And we have made such a big changes during those 40 years, but we continue to do it. Some of the lessons that we learned at the beginning in other areas of the country. We have moved to different locations and we are scaling what we have done at the beginning. I am a family physician, and then I got into public health, global health. And that was an encouragement that I got when I started working more consistently with women health in the most rural areas of Honduras. Can you put Olancho is one of the states that is one of the more isolated in Honduras. It's one of the poorest one. It's one of those who have less infrastructure. It's one of those who has more poverty and less roads. And therefore, the access to healthcare for women is very, very limited. One of the things that I was able to see at the beginning was that it was complete absence from, it's the previous one. It was a complete absence from the government. No clinics, no medical activities, nothing, absolutely nothing. In fact, there was a lot of population going to the really high hills because those are the only places where they could afford a house to live. And then that tells you that you're dealing with the poorest people. So again, there was no personal train in the villages that will be willing to go and work with the women in those difficult locations. At that particular time, when I started working in Honduras with healthcare, the epidemiology of women's health was horrible. in the 90s and the 80s and 90s. And the woman mortality was sometimes in some places between 150 and 200 for Southern live births. And then the infant mortality was between 51 and 55. And the rural areas, we had, with the research, with the large research, we had that was 20 to 40% higher in the areas that are more rural. And that is the reason why we have chosen to work with those people who have less access, who have less attention from different areas. And when I went, because I'm a Honduran and I live in the States, but now I work here in the villages too, is that those numbers of women and children who die, they represent mothers who die during childbirth. And I have had the experience that through the years, some of those women who died during delivery, their children became, one of them became my EA, my executive assistant later on in life. So it has been just really beautiful to see how those things have evolved and how those numbers have decreased. For example, the maternal mortality that is now 47 and the infant mortality is about 12. But that has taken a lot of work, especially in the most rural areas where women have hardly any access. There are a lot of those babies that don't celebrate their first years of birthdays, those children less than 5 that die. And they represent families that don't have any hope or any opportunities to survive, really difficult conditions. Looking at this situation, the Predesan approach since the beginning was how can we build healthcare for the most dispossessed, for the people that don't have any access, because we have some of the areas around where government has some, even small presence was a completely different for those who really didn't have any access, where you have to go to those places either by foot or ride on a horse. Sometimes we will go 6 o'clock in the morning and leave the cars near a river and get to the other side at 6 o'clock in the afternoon. At the beginning, I will just kind of stay there for a week or 2 weeks to do house clinics, to do clinics in the schools, and to see patients, with things that were so preventable, like cervical cancer, breast cancer, bleeding, vaginal bleeding, women dying of those things that they should not be dying at that particular time. And that was something that really touched my heart and pushed me or encouraged me to go and study more public health. So one of the things that we did from the beginning was like, how can we provide access to those women to have deliveries in more modern facilities? Because the deliveries were occurring in the villages, and who were doing those deliveries were mainly TBAs, traditional birth attendants. And who trained those traditional birth attendants? The grandmother, the mother, and all this traditional knowledge in the community. So that was our first focus. And we did train over 500 TBAs in those communities in the first area where we started working. And we saw such a big difference because the main causes of death were vaginal bleeding, and then it was like the bad presentation of the fetus in the womb, on the mother's womb. So one thing that we learned, and it's something that we have been reproducing, is to teach those TBAs 2 basic things. One was do a clean delivery. Do a clean delivery so you will avoid infections and therefore deaths for mother and children. So we provide them with the burden kit, where they could have a plastic thing, where they could put it in the bed and the floor, whatever place to deliver babies. We provide them with the iodine, with all the resources for water and for cleaning, and just having a clean delivery was just so wonderful. One thing that I was so excited about it is to see how women were really fast in learning the fetal position. You know, when we trained them, they were able to say, okay, you know, this baby doesn't have the head down. You know, this baby is just transversal. This baby is in this way. And then we trained them to do a quick referral, because it's not like you have an ambulance and you have another clinic right there to do the referral. You have to learn how you're going to take this woman out, how you're going to transport it, and then where are you going to send it. You know, it's not like there is somebody waiting there for you. So that was one of our roles, you know, to help those women to overcome those barriers. So developing transportation was a big deal. Negotiating with the community was a big deal. Negotiating with the husband to let the woman get out of the village, That was a big, big deal, you know, because sometimes they will say, just do whatever you can here. She can't leave because she has so many other children here. So, I mean, getting to know the community and building relationships with them, that to me is a big lessons learned. If you don't have that time where you establish relationship with the people, you cannot make an influence. You know, you cannot make an impact. So that was something that we did, training the traditional birth attendant. And then we started training community healthcare workers. We train community healthcare workers all over the different villages, and we train them to do other things like infection diseases, malaria, dengue, many other things, but also women health. You know, we train specific community healthcare workers to do prenatal control, to do immunization for women and children, to do nutrition for women and children, to support breastfeeding for women and children. So this was a big thing to do it just within the community. It was a child survival program that we launched with USAID for 7 years, you know, to be able to train women in dehydration. What do you do when your baby is dehydrated? What do you do when you have problems to do the lactation? What do you do for diarrheal diseases? What do you do for respiratory infections? So those were things that amazingly, you know, you have people in the communities. If you train them appropriately, they will learn. And then they will go, you know, we assigned a block or a village for a community healthcare worker. And you're going to screen and you're going to see what is going on in this community. We even established a contest. Who is the healthiest community? You know, community health competitions, you know, which community has more pregnant women in prenatal control? We'll just kind of give them a teacher and things like that will make them proud, teaching them to empower themselves and to be responsible for their own health. And one thing that I'm still proud of it is we developed the first auxiliary nurses program by distance. You know, we were in the villages where there was no trained personnel. So we have the resources to establish clinics, to do health centers, but who is going to go and work there? No one healthcare professional from the city is going to come and work here in those villages, even if you pay them a lot, you know. So we say, hey, let's work with the community here. We already have community healthcare workers. We already have PDAs trained. And then we launched the first auxiliary nurse program. It was a big thing to deal and will with the government, so they will allow us the certification for the people in the communities to become certified as an auxiliary nurses that could work in a health center. So this was a big deal because after we did it, you know, it was very hard at the beginning because government didn't want to allow it, you know, but then after it was done, and then it was like, oh, great, you know, we did this, we did that, you know. But the greatest thing is that the women adopted the program. And then they start doing auxiliary nurse program training in different areas of the country. And now that is going on all over the country. And then you have more auxiliary nurses that can run clinics in the most remote areas. We also train community leaders. Every clinic will have a community committee, and they will be the ones who will make decisions. And that is such of an important thing because they know what the people need. They know who is who in the community when we as outsiders don't know. So we decided we're going to go to the community where they invited us to come. And when they invited us to come, we will just kind of work together and we will establish the clinic. And then we expanded to agriculture farmers. We did the food security program, because people were having a hard time having a food security. But this was very helpful to develop relationship with the husbands, because in that way, they will have more trust. One thing is developing trust with the community, developing trust with the people was just one of the biggest things to make an impact in the community. Please, reproductive health, doing modern family planning, tubal ligations, vasectomies was something that they have never known about it. Cervical cancer and breast cancer prevention, something we started and we're doing now in a hospital. Dealing with the government, being advocates for the women's health in the villages has been a big deal. Having to go from the village at the beginning, going to the Minister of Health or going to the Congress to advocate for women for health has been a big thing here. So last one. Now we have a hospital. When we have a referrals, from the different villages, we have expanded to other areas in the country, and the plan is to be scaling more. And we say, we keep fostering health, wholeness, and hope, and that's what we continue to do now. Thank you very much.
Thank you, Dr. Madrid. I could listen to you for a long time, I'm sure. What occurred to me then is that to make change, we have to have enthusiastic, passionate people like yourself, and sustainable people, right? You've been doing this for 40 years, so I'd love to hear about your work. Thank you very much. So interesting.
There is a book where there is a little bit of the history of Pradisan. The name is Lay Down Your Guns. Okay. And you will think, why that title? One of the barriers we have to overcome was dealing with narco traffic groups in the village.
I think we need an entire book reading with Dr. Amanda at our next session.
I think we need a whole session with Dr. Madrid. Thank you. Thank you. All of the speakers are amazing.
I'm so sorry. I think we're out of time. We've come to the top of the hour, so we haven't even had any time for the questions. But just Margie, you chaired that session so well. Thank you for staying up so late and for helping us with this. And thank you to our wonderful panelists. I think we could have had a 4-hour conversation with each of you, just doing fascinating work. My apologies to the attendees who asked questions, but I think they're actually really good to finish on. We have a question from Dr. Kaz, who wanted us to share how can women leaders move beyond representation and become true architects of system-level change in healthcare, their organizations, and society at large, while strengthening the well-being and psychological safety of those they lead, which I think is a really good take-home question for all of us. And it also links to our next webinar, which will be on the 1st of September. And we're going to be looking at women leaders who are really supporting wellness and sustainable careers for women leaders. So it's all around workforce well-being and building that strong network of women leaders to move up the career ladder. So really hope you can join us then. But we'll leave you to your evenings, your mornings. Thank you all so much. And look out for the recording coming in the IHF newsletter if you want to revisit any of these discussions. Thank you all so much. Goodbye.
Thank you all. Thank you, Alana. Thank you, everybody.